the first part was good that we get to look at different mechanisms of action and some of the targets for some of these anti-seizure drugs. And so kind of like I've alluded to, this second half is really just kind of a laundry list of drugs, one after another. So it might get a little heady here and a little, just a lot of dense information very over an extended period of time. So please do feel free to either ask questions, or if you would like just even a pause, just go ahead and throw that up in the chat, and I will pause for a second and just ask if anyone has any questions, because again, this is kind of dense material and can get, because we've got a lot of different drugs to cover. Okay, so we left off talking about drugs that are used for focal or partial onset seizures. So if we kind of go back to that original characterization of what focal seizures are, they're seizures that originate in a single location within the brain and have not moved to bilateral kind of expansion. Now, as we're talking about these drugs, just recognize that some of the drugs do have application to generalized seizures as well. And then we'll also see in some instances these drugs shouldn't be used for other types of seizures. So just, I think it's always something worth noting as we're looking at some of their other applications. So a lot of the different drugs that we kind of listed there kind of first off were kind of first line approaches to drugs for focal seizures. A lot of them used voltage gated sodium channels as their targets. I think that's some reoccurring mechanism. So yeah, so basically this first list of drugs is going to be kind of our first onset. So carbamazepine is going to be obviously kind of one of the first drugs that is applied for this in this instance. Again, there are a lot of voltage gated sodium channel drugs here. So these are going to be kind of our first line for the partial onset seizure drugs. So this is, I guess, kind of where we're starting is talking about the second line. This is a different approach, a different mechanism of action that we're attacking here. So instead, we're looking at the inhibitor of the GAT1 GABA transporter. So this, again, as I alluded to earlier when we were talking about different mechanisms of action, this is almost akin to like an SSRI. You're blocking the reuptake of a neurotransmitter. So in this case, instead of something like serotonin, you're blocking the reuptake of GABA. So by blocking the reuptake, you prolong the time of GABA in the synapse, therefore allowing it to act on the postsynaptic receptor for an extended period of time. This particular drug is lipophilic, can be used as an adjunctive treatment for focal seizures, so it can be used with other therapies as well. You can see kind of a general dosage here, a dosage approach. Though it has some side effects. And again, as we're kind of looking at all of these anti-seizure drugs, I think the side effects are important to note, because often, again, that's what kind of decreases the amount of adherence of individuals, is because they essentially have things like nervousness, dizziness, tremors, or difficulty concentrating, depression, and very rare instances psychosis develop. So so these different side effects, again, are going to mitigate somebody's adherence to taking these. The pharmacokinetics, just very briefly, it's very bioavailable. Half-life is 5 to 8 hours, and it's oxidized by that CYP3A. So again, this is a second line for the partial focal onset, and it's a different mechanism of action that we're approaching here. Instead, we're targeting this GAT1 transporter. Our third line here would be another additional mechanism of action, a potassium channel opener. And so if you think about, again, synaptic transmission and what occurs, again, if you think of the brain as, or neuron as a salty banana, and think of the sodium and the chloride at high concentrations on the outside and potassium at a high concentration inside, as that potassium flows out of the cell, it makes it more negative, therefore less likely to fire an action potential. So in this case, this particular drug opens the potassium channel, causes potassium to flow out of the neuron, and thus making it more negative and more difficult for an action potential to fire. So when we talked about originally kind of how these epilepsies develop and things that we're trying to mitigate, we're trying to mitigate those reoccurrent kind of circuitry firings to occur, and we're trying to block neuronal action potential generation. And so by opening up that potassium channel, you're allowing that cell to kind of hyperpolarize to a certain extent and not necessarily fire as readily. Some interesting side effects to this particular drug is it causes discoloration of the retina and skin. And I put here that it's a PAM, or positive allosteric modulator. That's what PAM stands for here. So just maybe put that in your notes in case you're like, what's a PAM again? So it causes that channel opening to occur much more, either much longer or much more frequently. And so a positive allosteric modulator doesn't compete for the site action that an antagonist or an agonist would. It's got its own allosteric site. For the potassium K and Q channels. The dosage you can see there, roughly 600 to 1200 milligrams daily. The adverse effects, dizziness, somnolence, blurred vision, confusion, dysarthria. And again, what's interesting about this is it causes the lips and skin to turn blue. So this is kind of a very strange side effect that has been noticed here. And similar to when we were looking at kind of that kinetic graph earlier, this does fall into the kind of linear kinetics that we were plotting out earlier, and drug interactions to this are fairly minimal, but some of those adverse side effects, again, are partially why this is considered a third line approach. And I see Keith's face, so I'm excited to hear what he has to say.
Well, that blue skin and lips is certainly a unique side effect, all right, and it does remind me, this is just a silly little story, but going back to phenytoin, and by the way, I don't know why, but the name of phenytoin changed over the years. When I was first learning about this, it was called DPH or diphenylhydantoin, and then they changed the name to phenytoin, and I'm not sure why. But anyway, if you dig into the specific side effects of phenytoin a little bit, you'll find out that one of them is called gum hyperplasia. It's an overgrowth of the tissues of the mouth, gums, I guess. And when, as graduate students years ago, as we were taking the pharmacology course, one of my graduate student colleagues was a guy who was fantastic researcher, but he wasn't real hot about taking classes. But he latched onto this gum hyperplasia thing with phenytoin. And so after that, anytime a question came up with just about any drug, what are the side effects? He'd hold up his hand and say, gum hyperplasia. So, so anyway, just the blue thing reminded me a little bit of that rather unusual side effect with phenytoin.
And he was
And
right that one time.
Yeah, that's right. You know, where under toxicity, where it's talking about facial features, I don't know if that's exactly what I don't know what they mean by that, but that might be part of it. I don't know. So anyway, just some silliness on my part. Thank you.
Somebody asked about the pigment change and whether it was due to a decrease of vascularization or if it's a pigmentation change, and it's actually a pigmentation change that's occurring. There's no lack of circulation to these extremities. So it's not necessarily due to that instead. I think your textbook might go into a little bit more. I think it might have to do with melanin. I think, yeah, but I don't want to mislead you there. Lamotrigine is, again, we go back to sodium blocking channels used for generalized tonic-clonic. So just notice here that we've undergone a color change. So now we're going into drugs effective on focal seizure and certain generalized onset seizure types. So again, this is kind of the I don't want to say gray area, but it kind of falls under both focal and generalized. And so there's going to be a series of drugs that can be kind of utilized for both. This is generalized tonic-clonic seizures and generalized absence seizures. And again, those absence seizures, you might have remember them being called petit mal seizures. This may cause insomnia. So it's interesting to note that a lot of these drugs, because you're affecting synaptic transmission, some of them do have kind of that decrease in consciousness, almost a type of side effect. And we'll see that even when we talk about some of the other drugs that maybe we remember learning about previously when we're talking about other targets. These are fairly well tolerated, but again, you see kind of this laundry list of side effects. And then in terms of the pharmacokinetics, you can see it's completely absorbed, has about 55% protein binding, linear kinetics like we see with many of the ASDs, and then your typical dose range here. So if we're going to kind of, again, look at the site mechanism of action here, you can see this kind of laundry list of different sodium blockers up here, and this definitely falls within that range. So So again, it kind of just depends on the best way that you learn, whether you, when you're going through and you're memorizing these, whether mechanism of action is the way that you want to characterize them, or whether the type of seizures that they're applied to is kind of the way you'd like to characterize them. But I would probably recommend putting together some type of table, because I think putting together in that structure generally makes it a little bit easier to kind of compare and contrast the different drug types. Levetiracetam is going to be one of the more commonly prescribed. Now, this is, again, a different mechanism of action than what we've seen before. I've included this kind of image down here where it's showing you the difference in the SV2A synaptic vesicle integral membrane protein. So again, you're preventing loading of synaptic vesicles, therefore decreasing the amount of glutamate being released into the synapse. So used in focal seizures in adults and children, primary generalized tonic-clonic seizures and myoclonic seizures as well. Here you can get kind of a general dosage range. You can see, again, the differences in kind of consciousness levels for the adverse effects. Infection can also be a side effect here, which is one we haven't really seen thus far, things like dizziness. Pharmacokinetics, roughly your peak concentration hits in 1.3 hours. The half-life is 6 to 8 hours. No liver metabolism and drug interactions are fairly minimal. Again, you don't see it necessarily interacting with other liver metabolizing enzymes, so it's not surprising that there's not a ton of drug interactions there. And you're also kind of targeting a different mechanism of action than what we've seen with some of these previous drugs as well. Bivaricitam, it's a 4N-propyl analog of levetiracetam. A similar mechanism of action, it's going to affect that synaptic vesicle loading protein, reduces generalized seizures, linear pharmacokinetics that we see in some of the other anti-seizure drugs, and the half-life is 7 to 8 hours. And then some co-administration with carbamazepine and phenytonin can increase adverse effects. So I guess that's something to take into account when prescribing this particular drug here. Again, like I said, with these different drugs, different mechanisms of action are important to note. Peramipinil is a AMPA receptor negative allosteric modulator, or NAM, meaning that it doesn't necessarily compete for the glutamate binding site. There's another allosteric binding site that this particular drug binds to. And a negative allosteric modulator is going to either decrease opening time of that ionotropic receptor, or decrease the number of times that ionotropic receptor opens. And so essentially you're dampening down the postsynaptic response of glutamate released in this instance. So again, I think going over those mechanisms of action generally at the top of last hour was important, because here again, you can kind of start to think about where these drugs are targeting and the effects that they're having on synaptic transmission. Interesting to note that there are associated adverse reactions here that we don't necessarily see with some of these other anti-seizure drugs, things like aggression, hostility, irritability, and anger. I think the textbook also noted that alcohol can exacerbate some of these, not shockingly. Again, you have a kind of an additive effect of some of those, I guess, characteristics that you would normally see with alcohol. Here's when you see PK, again, pharmacokinetics is kind of the shorthand I'm writing here. So here's the PK, the half-life of this. So it's essentially a pretty long half-life here, and it's prolonged if hepatic failure is occurring in the individual, and 95% bound to plasma proteins. And then here you can see kind of the drug interactions that you might have with this particular drug. Again, some of these other anti-seizure medications that we've previously described. Okay, so again, phenobarbital we have discussed before. I just kind of like to put up some fun facts here about this one. In 1903, was found to induce sleep in dogs, so that's what it was originally, how it was originally discovered. I didn't know that. Oldest currently available anti-seizure drug, so this is historically what had been prescribed, acts as a positive allosteric modulator for the GABA A receptor. So again, we're talking about negative and positive allosteric modulators. So this positive allosteric modulator is causing an opening frequency or opening time of the GABA A receptor, thus allowing more chloride ions to flow into the cell, causing essentially synaptic depression. Used both for focalized and generalized tonic-clonic seizures, and then you can kind of get a general dosage range that you see there. But again, phenobarbital, I think we've discussed in other sections. Primidone, it's a derivative of phenobarbital, so it was used a lot in the 1960s. So again, phenobarbital might be kind of more historic. Primidone might be more a little, I don't want to say current, but a little more recently metabolized to phenobarbital, and then phenylethyl malonamide. And these all three act as essentially anti-seizures. So the original parent compound, as well as its metabolites, can be effective for focal and generalized tonic-clonic, can have sedative effects at high doses. Again, that's something that we've seen across some of these anti-seizure medications. And then you can see the general PK dosage range. And then once you get to the higher levels of concentration, some of the toxicity or side effects, drowsiness, dizziness, ataxia, nausea, and vomiting. So again, just kind of, again, going through the laundry list of drugs for focal seizure and generalized onset seizure types, this would very much be some, I think, more historical drugs that you might not utilize as frequently today, just because of some of the adverse effects associated with them. But with that being said, we kind of continually talk about how epilepsies are very idiopathic, and individuals will use what works. So I'm guessing if they've gone through some of the more current drugs that and have been proven ineffective, they might slowly work their way down to maybe some of these more classical approaches. Felbamate is used for focal seizures and Lennox-Gastaut syndrome, and we'll talk about a little bit more about what that is later, because there are some drugs that are specifically prescribed for that. Well tolerated, and can increase alertness, kind of a counterintuitive side effect there, but can cause aplastic anemia and severe hepatitis. So the mechanism of action here, it's a use-dependent block of NMDA receptors, meaning that only NMDA receptors that are activated will this particular drug bind to. So you have to have initial activation of those NMDA receptors, you have to have them open, and then this drug has to have access to kind of that internal, I guess, region of the receptor. Can also potentiate GABA A receptors, so most likely works in a positive allosteric modulator fashion. The PK, again, very well absorbed, excreted unchanged. You can see the CYPs in which this are responsible for metabolizing, and then generally what the half-life is if it's applied in a monotherapy approach. The dosage you can see here, 400 milligrams 3 times daily, but can decrease the clearance of phenytonin and valproic acid, and reduces the level of carbamazepine, but increases levels of carbamazepine epoxide. So, okay, so these were drugs effective for focal seizure and certain types of generalized onset seizure types. So now we're going to move to a different seizure type here. Again, the color change kind of indicates that transition. So drugs that are just effective for generalized onset seizure. So valproate, this is the first choice. This is probably one of the more commonly prescribed drugs for this particular type of seizure. It's a short-chain fatty acid formulated in oral syrup or gelatin capsules. So it has a coordinated complex for equal parts valproic acid and salt sodium valproate. Interesting though, its mechanism of action has not been determined, but is used in most seizure types. So it's interesting that it has been proven to be effective, although its mechanism of action has not necessarily been completely worked out. You can see here the PK, fairly bioavailable within a short, relatively within 2 hours. Drug interaction, so inhibits metabolism of things like phenobarbital and ethnosuximide. Replaces phenytonin from plasma proteins, increases clearance. So you can see here that there are kind of a laundry list of different drug interactions that it would have. So when you're prescribing this and other anti-seizure medications, I guess this would be very important to note, just because it has a lot of interacting kind of endpoints with these other drugs. In terms of toxicity, the effects things like nausea, vomiting, gastrointestinal pain, waking, and appetite and hair loss. And then idiosyncratic hepatic toxicity, meaning that it's fairly rare that this would be the side effect. I see Keith. Hi, Keith.
Hi, just a side note on valproate and going back to carbamazepine too. Some of you who are familiar with some drugs that have been at least partially effective as migraine prophylactic drugs would include valproate and carbamazepine. So that's not to say that migraine is a seizure disorder, but there may be some similarities in terms of underlying mechanisms between some types of migraine and some types of seizure activity. So anyway, I just thought I'd mention that as a sort of recognizing some multiple uses for these types of drugs. And interesting, as you note, not necessarily understanding the mechanism of action. Thank you.
Yeah, that is interesting. It's always nice when we can dovetail, the different previous topics that we've kind of gone over. So again, talking for generalized onset seizures, topiramate, the mechanism of action here, you've got voltage-gated sodium channels. It's blocking those voltage-gated sodium channels. It's going to be acting as a potentiator for GABA-A receptor subtypes, and then it's going to be acting as an inhibitor or possibly a negative allosteric modulator for AMPA and kainate receptors. This is effective for focal seizures in both adults and children. And used for Lennox-Gastaut syndrome, which we'll talk about here in a second, as well as juvenile myoclonic epilepsy, as well as Dravet syndrome. There will be kind of some brief descriptions of what those syndromes are. You can get a general sense of the dose here, 100 milligrams per day, and the side effects: impaired language function, which is pretty specific, impaired verbal memory, and general slowing of cognitive processing. So again, it seems to be, I think, a little bit more even focal in its effect or its side effects that we see here. General PK noted here, moderate metabolism, and then drug interactions. One thing to recognize here is that there is a decreased effectiveness of birth control pills that have been noted for this particular anti-seizure drug. Ethosuximide, first line of drug for absence seizures. So again, recognize that we've undergone a color change. So this is drugs that are effective for generalized absence seizures. Again, these have been classically called petit mal seizures. They're very short in time, generally 30 seconds or less. You'll see people just it's almost like a zoning out appearance. So those stare and strange facial movements. This is, I think, not necessarily more frequent in children, but is seen in children. May not realize that the seizure happened, and typically start between the ages of 4 and 12. So this particular drug, its mechanism of action are the T-type calcium channels. So it's going to alter presynaptic release of neurotransmitter. Used in the early 70s for generalized absence seizures. Here you can see kind of the rundown of the PK. It's orally administered. Peak levels of 3 to 7 hours. Here's a general dosage range. There is some interaction with valproic acid, and then in terms of toxicity, gastric distress, pain, nausea, and vomiting. Trimethadone is not available in the US. So again, I didn't kind of include its information here just because I feel like we're going through a pretty extensive list of these anti-seizure drugs. Okay, so again, we're going through a color change. So these are drugs that are effective. So we basically just went over the general absence seizures or the petit mal seizure drug of choice. Here you have the myoclonic seizures, such as the syndrome of juvenile myoclonic epilepsy. So here, literally in the text, it gave this setting, and then it just gave your laundry list of possible anti-seizure medications that we've essentially already discussed. So this is just kind of, I guess, showing you not necessarily mechanism of action, but just kind of showing the overlap of some of these drugs into other types of seizures. And I just included this EEG here. This is an example of a myoclonic seizure, a juvenile one. Just to give you a sense again on how these are diagnosed and kind of what this looks like when you're recording it. And so you can see kind of the synchronous misfiring of a series of different regions in the brain that are being monitored via EEG. So you can see kind of how that misfiring looks with those grand excitations of these movements across the brain. Okay, so again, shifting to yet another kind of heading. Drugs effective for atonic seizures, such as in Lennox-Gastaut syndrome. So here, again, if you're not familiar with this syndrome, it can be tonic, atonic, myoclonic absence, tonic-clonic, static epilepticus, or infantile spasms. For this particular Lennox-Gastaut, you use generally valproate with lamotrigine, and benzodiazepines. Rufinamide can also be applied here. It's a blocker of voltage-gated sodium channels, and you can see the general range of dosage as well as the PK, and it's excreted through urine. So this is just kind of, I guess, a single drug that kind of has its function or application here. But you can see previously discussed anti-seizure drugs can also be prescribed for this particular atonic type of seizure. Next, the drugs that are going to be effective for Dravet syndrome. This is a genetic disease where you have a mutation caused by a sodium channel mutation. So last lecture, Keith brought up the idea of a channelopathy. This would be a great example of a channelopathy where you have a specific mutation located in a specific channel, such as the sodium channel, that leads to a disease state. You can see here that there's this laundry list of drugs that we've kind of previously discussed that are applied, but it shows that they're kind of not really effective. Suropentanol is not approved in the US, but widely used in Europe. I just kind of included, again, this is a type of, because this is a channelopathy, generally people are born with this genetic predisposition for epilepsy. And so it is kind of a child's disease, but these individuals definitely survive into adulthood and are still, having to deal with this particular channelopathy. And you can see what I liked about this particular table that I included was kind of the differences and compare and contrast between a Dravet syndrome individual and somebody who suffers from focal epilepsy. Things like febrile and afebrile seizures, alternating unilateral seizures, and this is a unilateral seizure is always on the same side. So again, Dravet syndrome is going to look a little bit more like a generalized seizure. EEG generalized multifocal spikes, and EEG is focal. And then in terms of the mutation, this actually gives you the SCN1A mutation is going to be present in those folks with Dravet syndrome, and folks who have focal epilepsy will not have that. So part of the, the diagnosis would be genetic analysis to see if they carry this particular type of mutation. Continue to kind of, again, move through on yet another seizure type here. We have the infantile spasms, also called West syndrome. This West syndrome, this is an infantile, obviously occurs in young babies, can lead to developmental delays within those individuals. Probably the most effective drug here is abibitrin. It's an analog of GABA. It's an irreversible inhibitor of GABA-T. So we talked about how GABA-T was an enzyme that essentially broke GABA down in the presynaptic cell to its metabolites. Its half-life is roughly 6 to 8 hours. You can see the general dosage here. What's interesting to note here in terms of some of the side effects, retinal dysfunction, somnolence, headaches, dizziness, as well as weight gain. This might be a drug that's prescribed over an extended period of time for these kiddos. Okay, I've been going for a while here, so I'm going to pause really quick and see if there are any questions or concerns.
So I know that oftentimes people have to take more than one type of drug. And so would you like prescribe drugs that are from different classes with different mechanisms of action normally?
I think that sometimes can be part of the approach for individuals, is to see if they can get kind of a cumulative effect of multiple mechanisms of action. But as I kind of continually say, like a lot of the causes for these epilepsies are so idiopathic that it's hard to understand if a single drug will essentially not reverse that, but kind of mitigate whatever the original cause for it was. So I think as we're kind of seeing here, we're discussing all of the interactions. I think doing polytherapies or multiple prescriptions is a pretty common practice, but taking into account kind of how, if they can have different mechanisms of action, but always taking into account if they're affecting some of the downstream things like increases or blocking of CYPs to that could alter the metabolism of other drugs. I don't know if that exactly answers your question, but I hope it does.
Yeah, it helped. Thank you.
Yeah. Any other questions or concerns? Okay. Okay, so other drugs that can be used in the management of seizures and epilepsy. So we've talked about benzodiazepines before pretty extensively. But again, one of the major side effects of this would be is kind of the sedative effects, as well as the kind of increased tolerance. So here you can see kind of the laundry list of the benzodiazepines: diazepam, lorazepam, midazolam, clonazepam. This is going to be one of the most potent anti-seizure medications. You can see that the starting dosages for these are relatively small, and then are kind of just slowly are ramped up if necessary over time. Again, because of the main effect that you're concerned about here is going to be the sedative effects. I included this table here just because I felt like it did a nice job comparing, because we've looked at the benzodiazepines before. We've talked about things like their duration of actions, and then also obviously their usages are pretty wide ranging. You know, you can obviously use it as a sedative, as an anxiolytic, or in this case, we're using it as an anti-seizure medication. And so you can see kind of how some of the drugs are overlapping in terms of their use, in terms of their rate of onset, as well as their administration. So I just thought this was kind of a nice cumulative table, really wrapping up a lot of what we've talked about in terms of the benzodiazepines. I guess something worth noting here is, as we're looking at this laundry list of benzodiazepines, kind of how they differ in terms of their routes of administration. Okay, so as we're going over epilepsies, I guess I can kind of come back to that theme that everybody is going to be different. And then when you're prescribing these particular anti-seizure medications, it's important to recognize that, you know, you're going to have to generate a guided dose when dose adjustments when there is a change in drug formulation. You're going to also adjust drug levels when breakthrough seizures occur, when interacting medication is added or removed from the patient's regimen. During pregnancy, you're obviously going to have to alter what you are possibly prescribing to establish an individual therapeutic concentration range when the patient is in remission, and to determine whether adverse effects are related to drug levels, and to assess adherence. So these are kind of all things that need to be kind of taken into account when you're prescribing any of these anti-seizure medications. And as the patient's life evolves, as different situations kind of arise, it seems like a lot of these anti-seizure medications either need to change, or you need to take another look at dosage to see if it's still suiting that individual to the best of their needs, and still an effective anti-seizure medication given whatever current situation they're undergoing. This particular table was included, I think, in Goodman and Gilman, just giving you some comparative serum concentrations across these different drugs. So what is also kind of nice about these tables is it kind of breaks out some of the more classical drugs and then some of the newer drugs. And this is even broken out, I guess, into timelines where you can see some of the older drugs present here, as well as some of the newer drugs as annotated as being post 1990. So again, these are just serum concentrations giving you I guess, a relative comparison of each one of those, but it also kind of gives you a nice laundry list of each one of these drugs too. So as you're going back to study, you can be like, oh, well, where did that particular drug fit in? Or where's kind of a big list of all the drugs that we kind of need to know? I think this is kind of a nice place to come back to, because then you can start to slowly go through this laundry list and go through and double check and be like, oh, do I remember the mechanism of action of that? And hopefully you do. Okay, so when we talk about anti-seizure medications, there's obviously some kind of overall side effects that are seen for a variety of them. Tetragenicity, so there's not necessarily any anti-seizure medication that's been known to be safe for fetus. So there's actually been some tetragenicity seen in humans for valproate, phenobarbital, and topiramate. Recognize that a lot of them are going to penetrate the breast milk barrier as well. So it's very tricky to, I think, prescribe to both either a pregnant mom or a new mom. In terms of some of the research that's been done in suicidality, there has been just kind of a slight increase that's been observed, a less than 1%, but when compared to controls, there was an ever so slight increase in the suicide ideation. And then in terms of withdrawal, it's important to recognize that these drugs can't be taken indefinitely. There are some pretty serious side effects to chronic use. What's interesting to recognize is that obviously kids are there's a lot of plasticity going on in their brains, And so kids who are seizure free for a pretty good extended period of time, once these seizure drugs are withdrawn from them, generally after if they're seizure free for 2 to 4 years, they'll remain seizure free for 70% of those cases. So again, I think that kind of lends to this idea of their synaptic plasticity, that if they have intervention at an early enough age, that the brain can almost rewire itself to prevent those reoccurrent seizure pathways that maybe were there originally. Reoccurrence is more common in adults, again, because you don't have that same kind of flexibility with signaling. In terms of the future of epileptic drugs, so here you can kind of see that there is a whole variety of prescribed drugs that are kind of in the testing phase right now. So Staccato is a thermal aerosol inhaled drug that is used for acute repetitive seizures. You can see here intranasal midazolam, again, a different route of administration that might prove to be maybe more effective or easier to tolerate for acute repetitive seizures. Graganone for status epilepticus. What's interesting to note here is one, again, that we've discussed prior is cannabidiol for epileptic encephalopathies and focal seizures, as well as cannabidiol, which is used for focalized seizures. Cenobamate for focal seizures, and stiripendidol, which we discussed very briefly for Dravet syndrome. Something that might be worth kind of checking out too, like as you know, new and young pharmacists, I think being on the forefront of science is always very important. So here I just included a link for the epilepsy pipeline tracker, so you can see some of the new drug developments that are being made here. So just again, I think it's important that you recognize that there's constantly new drugs that are being tested, with hopefully fewer side effects that might have a higher level of specificity or a more targeted mechanism of action. And so this website, again, if this is something that you're interested in and staying kind of on the forefront of the research for this particular disease state, this might be something worth checking out. And again, this is actually provided by the Epilepsy Foundation, which I think is pretty great that they're able to kind of keep the I don't want to say general public, but general public kind of informed of where the new drugs are coming and how their development is going, I guess. Okay, I guess coming back to here. So ultimately, I guess that is all I have for the epilepsies. I think we went through a pretty long laundry list of drug names today, but I want to pause for a second and ask, are there any questions at all about the drugs that we discussed, about the mechanisms of action, about epilepsies in general? And I see Keith's face, so I'm hoping he has something to add as well.
A couple of things. One, with respect to new drugs, I'm not sure if this is still active or not, but I think it probably is. For decades, there's been a center at the University of Utah of regional interest that's solely been devoted to the development of new anti-seizure types of drugs. And for a long time anyway, a lot of the developments that occurred in the field were originating from that particularly dedicated site. I haven't checked recently to see if it's still there or not, but I sort of suspect it is. It's associated with either the School of Medicine or the School of Pharmacy there in Salt Lake City, or maybe with both. So just one little comment there about new drug development. Also, when you're talking about effects during pregnancy, it reminded me that when we were talking about antipsychotic drugs a week ago, I was supposed to look up, and I actually for once did look it up. The antipsychotic drugs are not, really super powerful teratogens like something like alcohol is, but there nevertheless is caution noted with respect to utilization during pregnancy. And, teratogenic studies and related adverse effects in fetal development are very difficult studies to do. And there's a lot of information that's still lacking with respect to the various impact of impact of various drugs during pregnancy. But I would say, this is a way too broad a generalization, but I would be leery of just about any CNS active drug in terms of negative impacts on fetal development, and try to go as cautiously as possible in that particular regard. Thank you.
Yeah, I think it's an important, I mean, when you're thinking about pharmacology, lipofacility and its ability to cross different barriers, if it's able to cross the blood-brain barrier, there's high chances of it to cross the placental barrier as well. And again, obviously a ton of neural development's occurring during that time. And so if you have a drug that's able to alter CNS function, you have to think about what effect it's going to have on overall CNS function as well. Keith just mentioned this epilepsy center at the University of Utah. So I just quickly looked it up here. So here you can see just kind of the webpage for that in terms of what the different study strategies they have available there, and give some general information about epilepsies. So yeah, I think I'm just gonna go back and ask, does anybody have any questions about the course overall, about what you saw today, about the exam on Friday? I think we've got a few minutes here to discuss any of that if anybody has any such questions. The void of quiet darkness says no. So yeah, I think that's ultimately kind of all we have for you today. If you do have any concerns, please feel free to reach out. Tomorrow we'll be talking about psychostimulants, so please make sure to attend if that's an area of interest of yours. And yeah, I guess we'll see you all tomorrow at 1 o'clock. Everyone have a great day.